Welcome to Economy Made Simple. I am Shamubeel Eaqub, the Chief Economist at Simplicity. There's a lot going on in the world right now, and I'm here to make sense of it. Brought to you by Simplicity, New Zealand's non-profit KiwiSaver and fund manager, who are on a mission to make Kiwis richer and smarter with money. Hello, and welcome to Economy Made Simple. Today I have a very special guest, Ashley Bloomfield. Today we talked about all kinds of things, from leadership to the future of the health system, but also how we can be hopeful and get the best out of all the resources and all the great people that we have in New Zealand. The conversation with Ashley was extraordinary. We talked about the value of people, the importance of people, and how that really drove his leadership and his decision-making through the COVID period and beyond. The reason I wanted to talk to Ashley was because he thinks about the future of New Zealand through the lens of people, as we do as economists when we're thinking about the future of New Zealand. It's about giving dignity to New Zealanders and making all New Zealanders better off. For me, the takeaway from this conversation with Ashley is that New Zealand has lots of choices in front of us. There are good choices if we're willing to take them. And to do that well, we need to have true leaders. They don't need to be innate leaders. We can invest in people, we can train them up, and it's entirely possible. What I left with was a sense of hope that New Zealand has a positive future if we work together. I hope you enjoyed this conversation with Ashley and get some insights like I did. So Ashley, your career started as a doctor, particularly specializing in public health, and then you were the face of, the COVID response in New Zealand. And you've been doing a lot of work recently around what can we do to really fix the system over the course of the next little while, a hopeful picture of how to improve things in New Zealand. So I really want to talk to you about that today. But do you want to give me just a little bit of a potted history of your career in terms of where you've come from?
Well, kia ora, and thanks very much for having me here today. I went off to medical school, made the trip from Tawa, where I grew up near Wellington, and hit the big smoke here in Auckland, did my medical degree. And then after a few years decided that public health was the training, or the specialty I wanted to do, and I did that again back here in Auckland. My master's in public health, and I've always been a sort of a jack of all trades, so I got a lot of different experience, and towards the end of my training thought I'll go to Wellington and get some experience in the public sector. So my poor wife and with a young baby, we headed down there, and over 25 years later we're still there. I just found that nexus between public health and the public sector really was a place I enjoyed, and spent much of my subsequent career in the public service, Ministry of Health, but then also a pretty decent stint out working in district health boards, including a few years as a district health board chief executive down at Hutt Valley and Capital and Coast, and then applied for the role and got the role as Director General of Health. I didn't know at the time that there was a global pandemic coming. I should have read the fine print, I guess, on my contract, but that came along, and I did the 4 years that included the COVID pandemic, as I guess many listeners will know.
I'll touch on the pandemic, but can you just describe to us what public health is?
Yeah, well, I think of public health as taking care of populations rather than individuals. So it's the sort of things that we do, not just through our health system, but as a broader society to protect and promote and improve people's health. And it requires you to take that broader population perspective. And I guess that's what I really like about it, is looking at the big picture. And, a good example is an area that I spent quite a bit of time on early in my career was around tobacco control, stopping smoking. And when I started in that area at around 2000, over 35% of our 14 and 15-year-old Māori girls smoked daily. 37%. It's now under 5%. And the reason for that is not because suddenly they've realised smoking's bad for you, but actually a number of interventions and changes in the policy environment, increasing the tax on cigarettes, regulations that have actually created taken a system approach and led to that reduction in smoking amongst Māori girls. And the intergenerational impact of that is quite profound.
Yeah, and I guess you might be wondering why you're in a podcast about the economy. And I guess in my mind, at least, the economy is about people. And when it comes to our people, our health, the way that we operate in terms of the wider systems view is really, really important. And so public health is quite a big part of how I think about the economy and society. I was really intrigued when you recently talked about that kind of 10-year vision for health. And I think you were touching on that public health aspect, but also lifting our gaze, not only focusing on what we do today in terms of wait lists or surgeries, but taking that longer term view of how do we make progressive improvement over time. Can you tell me a little bit about what is the problem and how you think we can actually have a plan that will last over a decade?
Well, there are a few things here. The first is, let's be really clear, ageing is humankind's greatest achievement. And it's only really in the last few decades that more adults than children have died each year globally. And of course, it's not surprising, as you say, the economy there is to serve people, and people value living long, healthy lives. The health system's made a significant contribution there, but some of those broader public health interventions have been really quite important, and including even just safe water and sanitation have made huge contributions. Access to food, access to recreational opportunities. These are all things that impact on people's well-being and their ability to fulfil their aspirations in life. So saying, an ageing population is also one of the biggest challenges and probably the biggest driver of demand on our health system. And partly this isn't surprising because actually the biggest risk factor for most of the common diseases like heart disease, cancers, the biggest risk factor is age. These diseases all increase with age. So it's no wonder that our system has had more and more demand on it and more pressure on it. But these are not new challenges. And I like to go back to the report that was published in 1988 called Unshackling the Hospitals. Alan Gibbs and colleagues wrote this report. And the diagnosis of the problem was waiting lists, inequities, low morale, financial issues, and something else they called inadequate management, or a phrase like that.
Sounds very familiar.
Sounds very familiar. You know, these are not new problems, and likewise, they're not unique to New Zealand. They're challenges that all health systems are facing, and again, not just in high-income countries. So the question then becomes, are we doing the right things to address these challenges, or do we need to sort of change our game? Being a large, complex system, it's not easy to make change within the health system, but it is absolutely possible. And I think one of the key things to actually making the changes that are needed, given the problems are not new, is to actually harness the energy, harness the smarts of the people in the system and give them a real sense of hope, actually create that sort of, not just a 10-year vision, but a plan, a pathway to get there. And I think we'd see not just energy and enthusiasm and innovation to help us achieve that, but it would actually take us down the pathway to resolving some of these long-standing challenges.
So this hope that you talk about, so I guess what is the vision that these people are uniting behind? Is it simply that we have a better health system, or is there something else that you can see that's people already are driven by?
Well, every day I do, and I don't know about you, but I speak to people who've had experience, or their loved ones or their friends have had experience of the healthcare system, and virtually to a person they say, oh my goodness, the care was amazing and the people were fantastic. So there's no doubt that our system is probably as good as any globally. If you need acute care, you get really good care and you get high quality care. And yes, there are still disparities and inequities in outcomes, inequities in both in access to, experience of, and outcomes from care. But even those have been improving in many areas over the last couple of decades. The real challenge is those conditions of older age include, the need for elective procedures, or planned care as they're called, in particular things like cataract surgery, hip and knee replacements. And if people have to wait for those when they might be in pain and their quality of life is reduced, then that is a really big marker of the need for us to sort of think of providing that sort of care differently. And that may be not just how we give them access to procedures, but how we provide other options for them in the community. For example, in terms of hip and knee replacements, there's really good evidence that good physiotherapy can improve the quality of life of people and defer the need for surgery. Yet we haven't really got the system set up to provide that easy referral to physio or occupational therapy or what it might be. So it's really thinking about what are the different approaches to delivering care, and in particular, strengthening care in primary and community settings. That's got to be a really big focus. And successive governments in New Zealand, as well as globally, have made that point, yet the funding and the resources tend to flow into the hospital system.
And that's interesting, right? Because I think what I'm hearing from you is we have an acute system that's actually pretty good, and I can speak from my own personal experiences with my family that you do get extraordinary service when you're in desperate need. But I guess those elective parts are where the wait lists are, and quite often those difficulties arise. But what you're describing is, I guess, devolving some of those into more community-based solutions, but also to have better clinical pathways. So different ways of dealing with the same problems that might not need surgery or some of those more acute interventions. But it doesn't seem like those things are ideas or policies or approaches that we are implementing. What's the holdup in actually putting money and resource into doing those things that seem like would work better?
Well, this is the big challenge for the system. And coming back to primary care, in New Zealand in 2001, we published a fantastic primary care strategy. And if you went back and revised that and rewrote it today, there'd probably be not much you would change about it. It was a great vision and a great sort of pathway for the system. And successive governments said, yep, this is the way we've got to go. Well, since 2000... In 2000, 37% of our doctors in Aotearoa, New Zealand, were working in general practice. That's now 24%. Yes, there's been an increase in the number of GPs, but there is this sort of a colleague of mine, Tim Tenbinsel, who's a professor of health economics at Auckland University, talks about the black hole, this gravitational pull of resources and people into the hospital system. Because we've got to remember, hospitals are publicly owned, and almost uniquely in our system, that's where care is publicly delivered. Most other parts of the system are actually privately owned and privately delivered. So there has been this sort of gravitational pull away from primary care into specialist services, and it's going to take very deliberate actions and decisions to switch that back. Because for many of these chronic conditions, actually it's their management in primary care, early detection, for example, of cancers in primary care. So good access to primary care leads to better management, better outcomes, and then subsequently less pressure on the hospital system. As I say, though, that's going to take, thinking about the system over a 5 to 10 year period to make those shifts.
But it sounds like when we talk about the politics, it's about the immediate wait list. It's about those immediate issues. How do you kind of find that ability to talk about those longer term issues, which inevitably require some kind of trade-off? I think that's the bit that's difficult in the politics, is how do we tell our voters, be patient while we invest in primary health, and eventually there will be less of a wait list? So
I think there's a fundamental point here is if you've got good access to primary care, it doesn't necessarily reduce demand on secondary and tertiary hospital care. In fact, you may uncover unmet demand. There may be people who are out there who have got conditions, chronic conditions, that actually would benefit from specialist care. There are a couple of things here. The first point is how we deliver that specialist care. It doesn't necessarily need to be all locked up in hospitals. If we can enable and support primary care to have access to specialist advice, to be able to refer for routine diagnostics, particularly radiology, X-rays, CT scans, MRIs, it's very hard to access those publicly funded from primary care. Whereas if you turn up at an ED, you can access all those investigations almost on the spot.
But don't we have capacity constraints in our diagnostics?
We have capacity. It's just where that capacity sits.
Right.
Most of our diagnostic excess capacity, radiology capacity, sits in private. So it's then about what sort of models, what sort of funding mechanisms, what sort of incentives we put in place. But there's another fundamental question here, and that is how much as a country are we prepared to spend, publicly spend on healthcare? And whilst, when I started in public health in the mid-90s, I can remember that some of the Treasury reports that would raise the spectre of this sort of uncontrollable increase in health care if we didn't do something, so-called scissors of doom. If you look at the graph, that's what it looks like. Actually, since 2000, we've spent about the same proportion of our GDP on vote health. It's gone up and down a bit, but it's around 6%. So in 2000, we spent about 6% of our GDP on vote health. It's still about 6%, maybe a little bit more. But there's been a big increase in our overall GDP spend on health, and most of it now is coming out of people's pockets. So that's a deliberate decision, or it may not have been overtly made. But with an ageing population, and if we really do value healthcare in terms of the support it provides people to live well, then as a country, we actually have got an option to increase the pie. And then one can do both. You can keep improving the access to specialist services and improve access to primary care.
But I guess, isn't that the dilemma? That because we haven't increased the amount of money that we spend on health as a share of our economy and share of our taxes, that's the reason why we haven't been able to invest sufficiently in primary health. That's why we have wait lists. These are not unrelated things.
They're absolutely closely related. So we could make a choice as a country. If we were to spend, you all know what 1% of GDP is. It's maybe, $3 to $4 billion extra a year.
$4 billion.
Now, that doesn't mean that every dollar we're currently spending shouldn't be scrutinised and spent to achieve good outcomes, and not just good outcomes, but good equitable outcomes. So it needs to be spent fairly. But if we really want to invest in primary care and address those waiting lists, and both need to happen to improve people's well-being, then that's a decision, a choice we could make. The question then becomes, how might we fund that? And of course, that's when you start to look at options about increasing taxes, and of course that's much more your purview about how one does that.
We haven't had much luck raising taxes sustainably in New Zealand, so it might be more around efficiency gains and maybe other ways of funding services. I guess if we come back to the beginning of the conversation, we talked about hope, and that not everything is broken in the health system, that there is a more hopeful, positive future. How do we get there? Like, what does the 10-year plan look like? What are the kinds of things we can do to get there?
Well, you start with the funding, and I think giving some certainty about the funding, and then it's what you invest that in. The biggest investment, of course, in our system is people. It's the workforce is the largest, you might say, cost. I prefer to think about it as investment. I think one of the things we absolutely need to do is have a more sophisticated discussion about the workforce. If I asked 100 people on the street in New Zealand, have we got workforce shortages? I bet you that 99 of them would say yes in our health system. Actually, a couple of figures here. Between 2018 and 2023, the number of doctors employed by Health New Zealand went up by 23%, and the number of nurses went up by 23%. The population increased by 6%. The issue here, as I alluded to earlier on, let's think about the medical workforce, is not the number, it's about its distribution. We've got a shortage of doctors, but that primary shortage is actually in general practice. It's out in the community. It's not necessarily inside our hospitals. So I think we need to have a more sophisticated discussion about not just the workforce, but what sort of professionals are we training? Not just how many of them, but what are we training them to do, and also how we're deploying them. And if you take a 5 to 10 year view, you can actually map that out, and by doing that, actually really shift the way care might be delivered. I think some of the other things you'd want to look at are areas like mental health and how we can make access to mental health services, both primary and specialist mental health services, and think about new ways of doing that. Try some things. This is one of the things we did well during COVID as a country. Because there were so many unknowns, we had to have this real innovation mindset, review, learn, adjust, sometimes on a daily basis. So taking a mindset that's trying some things and learning quickly, not fail fast, I prefer to say learn fast, and then adjust, And you've actually got people in the system who have such energy and ideas that I think if we could tap into that, it would really make a difference.
Are public servants allowed to take risk in a non-crisis situation? Because it seems to me that the measure of success in a lot of public policy is not to fail, not to learn and succeed by learning, but to not fail. I think the pandemic was very unusual when we did see that fast learning, fast failing aspect that you talked about. But I don't see that as a normal way of operating in the public sector. Now, what's your kind of reaction to that?
This is one of the big challenges here and in other countries. And it's something I noticed a shift in during my career in the public service. So I started in the late 90s. Well, in the early 2000s, even as a relatively junior person in the Ministry of Health, I might have been a public health advisor or chief advisor of public health, I would often front issues in the media from a technical perspective. It's very unusual now to see any official, short of a chief executive, and usually only then when something's gone wrong, and they're saying, I'm going to, own it and learn from it and fix it. These issues tend to be incredibly tightly controlled, not just out of the minister's office, but even through the Prime Minister's office. And that's, again, it's not unique to this government. It's something that's happened over time. Part of that is, I think, an interesting observation I made through my career was the rise of the political advisor inside ministers' offices and the extent of their reach into the public service. And as you say, one of the outcomes from that is that whilst there's, on one side you'll hear people saying the public service just needs to take more risk. In fact, they're now, public servants are working in an environment where there's very little scope to take risk. And as soon as something doesn't go right, the fingers are pointed, and if it's not the media, it's others who are asking for someone to resign.
Heads will roll.
Yeah.
And I guess therein lies my discomfort with the changes that are required in New Zealand. I think we can see New Zealand has a lot of positive things. I think there are lots of opportunities, but we will not be able to grasp those opportunities if we're not willing to take some risks and learn from them. But if our public service and our politics is risk averse, then how will we make those changes? Maybe we could reflect a little bit on that pandemic period, because you did do a lot of quite innovative things. Not everything went right, but you learned from it. Do you want to take us through a little bit of the time to give us some reflections on where did the permissioning come from? Was it just from the politics, but also, or was it also from the public?
There were some really key lessons there, and whilst we have to acknowledge it was a crisis situation, people were scared, particularly at the start of the pandemic as it unfolded. But there were some really interesting lessons about the importance of building public trust and what does and doesn't build public trust. And I guess I was in a slightly different position from the politicians I might have been standing beside, because I wasn't a politician, although I dare say there are many New Zealanders who didn't necessarily make the difference. Often people come up and say, oh, you were the Minister of Health, weren't you? But what I learnt was actually what builds trust is being honest, being reliable, and being competent. And it's okay to say, actually, that didn't go right, and here's what we're going to do about it, and I'll come back and I'll let you know what we've learnt. It's particularly okay to say we don't know, and now we make it very difficult as a public. We don't provide really the space for our politicians to say, I don't know, let alone, oh, well, that didn't go right. We sort of have a higher standard that we expect of them than we do of ourselves in many ways. But actually being honest, being open, including about what we do and don't know, builds trust. It doesn't undermine it. And people are very discerning, and that's something that was really hammered home for me through the pandemic. People know if you're telling the truth, and being honest, being reliable, and showing a degree of competence actually builds this trust, which then gives politicians and gives decision makers the opportunity to really ask people to do things that otherwise they might necessarily not want to do, and also be patient. So I'm a big fan of thinking hard about what we can do to build trust once again, not just in government and politicians, but also our media, which has got a low degree of trust in New Zealand compared with other countries.
Yeah, I was going to ask you about that because I think you're absolutely right. In the beginning of the pandemic, there was a huge amount of trust and reliance on official advice and officials and the politicians. But it seemed like over the course of the pandemic, that faded over time. And certainly, some of the pushback we saw, for example, through the protests, there was a small group of people, maybe not that small, who really resented and were opposed to some of those changes. Is it just a reflection of, I guess, fractures in society, or was there something else going on that might be, I guess, symptomatic of why we are finding it difficult to make some of those longer term changes?
Well, I think this is a big challenge, and it probably goes into the whole area of what I now call harmful information, or harmful misinformation. Sometimes deliberately intended to be harmful. At other times, just people don't actually know, but they're spreading that information. And we know that there are sort of efforts to spread that sort of information from nation states around the world, deliberately designed to try and generate actually dissent and fractures in countries. So this is where we need to, in a sense, as a country, be aware of that, but also be really clear, actually, as we did during COVID. If we're really clear about what it is we want to achieve and have ambition and have a sense of hope for the country, that becomes less of an issue. And during the pandemic, I was asked, well, what are you going to do about the disinformation about vaccines, for example? And my response was always, I'm just going to focus on providing good, accurate, clear information as much as possible. And the fact that over 90% of New Zealanders aged 12 and over had at least one dose of the vaccine, and over 80% on average had 2 doses, shows that actually if you do stick to that and provide good information, and that was quite late on in the pandemic, that
Yes.
didn't really, the main vaccination program didn't really get started until well into the second half of 2021. So people still had a high degree of trust in the information that was being provided and acted on that.
Are there some lessons from that for how we lift child immunization rates in New Zealand? Because that's been surprisingly low in New Zealand and falling in recent years. Are there some lessons that we could take? Because it kind of comes back to the public health conversation. I feel very concerned that we have children that are not being immunized, that are not accessing healthcare at the right and timely ways.
Yes, this is something that's been seen globally, actually, is this drop in childhood immunisation rates. When I first started in public health in the late 90s, actually I was working here in Auckland, and we had a measles outbreak in Auckland, quite a big one, and we managed to get on top of it. But at that point in time, our vaccination rates were lower than they are now.
Wow.
And we had spent quite a while trying to think about what are the ways to improve those vaccination rates. And actually with a lot of effort and a lot of work and some really skillful sort of oversight and policy and funding, we got up by 2015, our childhood vaccination rates were close to 95%. There was a bit of variation by ethnicity, but all 3 major ethnic groups, Māori, Pacifica and non-Māori, non-Pacifica, were all over 90%. And that dropped after that point in time. It had already started dropping ahead of the pandemic. I'm very confident we can get it back up again, but it just requires a really systematic approach and having good data and having people out there using every opportunity to vaccinate children. We do know in Aotearoa, as in other countries, there's the group of people who really don't want to or don't intend to vaccinate their children has increased slightly, but it's still less than 10%. So anything less than 90% means that we're missing a trick, and we've done it before, and I think we should go and have a look at what worked previously.
It seems to me like when it comes to public health and public policy in general, it's something that's progressive. The job is never done. You just have to stick at it. Like you said, when we wanted to improve that immunization rate, we put in the effort across multiple different actions, and it worked. But is that any different today to any of these problems we're trying to deal with, including the 10-year plan of health that you're trying to imagine? Isn't that what it's about? It's for us always to be trying to make that progressive change towards something that's better.
This is really important, and part of my commentary around the health system at the moment, you might have heard me, is saying, I don't buy into this narrative that everything is failing or that it's a crisis or that the system's broken. And one of the reasons I really don't buy into that narrative, and this is I call them the media's favourite F-bomb and C-bomb, failure and crisis, because every heading or second heading has got those words there, and it's an easy narrative to create. But what it does is undermine the real agency that we actually have, both as individuals and as a country, to address these issues. And that's why I'm big on this idea of hope. Actually, the challenges we're facing in the health system now are neither new nor are they unique to New Zealand. And if any country, in my mind, can actually address them, it's Aotearoa New Zealand. So I think what we really need to do is remind ourselves, and there's this new word as well, polycrisis. The whole globe is one big polycrisis apparently. Actually, we've got enormous agency, and we showed through the pandemic that if people have got a really clear sense of purpose, if we build trust, and if we work together and take a really strong values-based approach, and economics is a values-based discipline. If we take a strong values-based approach and think about those values that as a country are important to us, we can achieve quite amazing things. There's nothing now that would stop us or prevent us from solving some of these and making progress on some of these really big challenges, including the ones that our health system faces.
Fabulous conversation. To me, I heard a few key things. One was around that shared purpose vision. That's something hopeful for us to look forward to, that is a better future as possible. But I heard from you also this idea of devolution, of getting closer to communities, closer to the people who need things, and that idea of primary care, which I think resonates for me very strongly as something that's much more grounds up rather than top down. But I also heard our need to work together in a much more coordinated, long-term way. And I guess that's probably the one that I worry the most about, that our ability to coordinate seems to have diminished over time, that we've become more short-term. And I'd be interested in your thoughts around where you think that antidote is. Is that antidote to short-termism, will that come from politicians or will it come from the public?
It's a really good question to be able to respond to. I did a course at Oxford University in 2017, and one of the things that stuck in my mind was that talking about these really big complex issues, global complex issues that we face now, climate change is a good example, is that very often there is not the political or social license for politicians to lead, so others need to lead. And that could be businesses, the private sector, it could be civil society, it could be communities, professional groups. And I think the vision for the 10-year plan that I'm talking about is one of those issues that actually, if the political sphere doesn't create an environment that politicians feel, because of partisan political reasons, that they can lead, then others should step up and in. And that's why I've been really interested over the last few months to talk to people from a range of perspectives, including private sector players in the health system, businesses, health professionals, people working in the system. No one has said that it's not a good idea. There's really strong support. And so my view is that it's an issue that's really ripe for people outside of the political process, outside of partisan politics, to form a broad sort of alliance around and take it forward. Health, like many of these big societal issues, is political, and it should be political because it's about values, it's about trade-offs and decisions around allocation of resources. But if we can take it outside of the partisanship for a while and get a broader range of groups moving that issue forward, so that then political parties can look and see, actually, this is something that's valuable for the country and put their energy behind, I think that maybe offers a way forward.
So Ashley, I think what you're doing now seems like a personal leadership issue, that you're out there talking about this issue because you believe in it and you have credibility to talk about this. How do you view leadership in this space, but also in terms of how you practice it inside of the organizations that you lead?
Well, this is great, but let me start by saying I might be someone who's recognisable, but leadership is a team sport. I talk about leadership as being an invitation to collective action. I really love that definition. Leadership's not about an individual. It's not about the prominent person, the charismatic leader. I'm not sure it ever was. But the other thing about leadership is people aren't born leaders. Leadership's a set of skills and behaviours and practices that you learn over time. And in particular, fundamental to good leadership is self-awareness. So I really think about it as a lifelong journey in self-awareness. I'm still on it, and I slip up quite often. But this is, I think, the potential of taking this issue of the 10-year vision forward is how well we can build an alliance or a team around that idea. And again, that was our success during COVID, was the ability for people to feel a common sense of purpose. And then actually, and this is a really big lesson for leaders, often we spend too much time in our organisations on the what and the how, not enough on the why. If people, as we saw through COVID, understand the why, actually, guess what? They know what to do. And they get on and do it. In fact, they tend to exceed our expectations if we had any in the first place. So this is the sort of leadership we need in our organisations, in our communities, and indeed at our country. Leadership as a team sport. It's not about individuals. It's not about point scoring. It's about extending that invitation to collective action in a way that generates energy and hope and a sense of purpose. And this country, we have seen time and time again examples of that leadership really taking the country forward. And I do hope, and again, that's not a leadership responsibility just of our politicians. It's a leadership responsibility of our business leaders, our community leaders, our people who are in privileged positions, whether that's financially or in positions of power, to take that collective approach.
Does it differ in terms of this collective public thing that you're trying to do, that stepping up, I guess, which is quite unusual in New Zealand because we do have a little bit of fear in stepping out into the spotlight. Was that a deliberate decision on your part in terms of wanting to do something for the system because you saw an opportunity or because you felt a responsibility?
It's both, actually, and in part because I had a public profile during COVID and people sort of know who I am. I'm wanting to help create momentum. I'd be very happy if anyone, including political parties, picked up the idea of the plan and owned it and drove it forward. I'm just using the opportunity really to start the conversation to see if I can get some momentum around it. And again, the idea of leadership has been a team effort. It's through collective energy and collective action, really, that we do see progress on these issues. And sometimes that happens when we least expect it. It's quite extraordinary. I've seen that time and again in my public health career, because public health is a very long-term game. You have to be tenacious. No one thanks you, writes you a card or sends you some cookies for preventing the cancer they might have got in 20 years' time. So you've really got to take this long-term game. But again, I just come back to the example around smoking, where we've just seen this absolute shift in this country that will have a profound impact on people's well-being and the health of our communities, in particular those like our Māori communities that had high smoking rates and experience really inequitable health outcomes.
I was doing this roadshow once, and there was a leadership guy, and he described leadership as somebody who can see the future or imagine a future and take their people with them, which I think sounds very similar to how you describe it, which is about that team sport of having a really clear why and purpose and energizing that energy of your team and the expertise that sits inside of your organizations to unlock that.
Yeah, absolutely. And that's where you see the best leaders are the people who can inspire. But it's not, and there's this difference between setting the direction and ensuring there is direction. And that's why I like this invitation element of the definition. Actually, a really good leader won't go in there and say, here's where we're going. They actually engage people in a way that then people decide for themselves, this is where we want to go. So it's that extension of an invitation. It sounds, it sounds subtle, but it's really important. And, that leadership being a shared responsibility, because one person can't and shouldn't, be the only one that everyone is relying on.
You've run some pretty big organizations. How important is management and management structure to do that? Because, when we're talking about health in the 1980s, you talked about how the management deficiency was a big part. Was that an issue that you've seen across your career as something that can make or break the success of a leader or the outcomes?
So the structure is often a distraction, and we see this in health systems around the world, particularly English-speaking health systems, where because it's so complex and change is quite challenging, governments or ministers come in and they say, I clearly need to do something, and often the only lever or the biggest lever they've got is to make structural change. That tends to create a lot of disruption, but it doesn't necessarily change the underlying or address the underlying challenges or issues. And to make a distinction between management and leadership in a complex system, like a health system, and it was management guru Peter Drager who nearly 50 years ago said the hospitals are the most complex organisation humankind has ever sort of invented. Well, if you put hospitals inside inside the whole health system, you've got real complexity. So it does require leadership. It's not about a command and control, a management type approach. Yes, you need excellent management. I've yet to meet a great leader who's not also a great manager. But that leadership is about values, behaviours, relationships, and really energising people so that they want to be part of achieving a shared outcome. And the real kicker here is if you can generate that sense of collective purpose where you then unleash discretionary effort and discretionary energy, and that's about engaging people. We saw that happen through COVID, and I've seen it happen in the health system as well. There is this real latent energy and belief and absolute commitment that if you can unleash it, it's very powerful.
To me, it sounds like you're describing really good culture.
Absolutely.
There is an organizational culture or a sector culture where it's positive, it's hopeful, and if you can unleash that, that can have really good outcomes. Sometimes I kind of use a very pithy kind of, maybe it's too simple, but I say good leadership, good management, and good culture. That's the secret sauce of any successful organization. It's very easy to say, but hard to do. Any reflections on, how to kind of create that good culture in organizations?
This is something we really focused on when I went into the Hutt Valley District Health Board, and then again in the ministry, was working out as an organisation, what are our values, what's important to us, what do we want to deliver for our community, for our patients, for their whānau. And yes, it's challenging, but it's in a way also simple, and it's like all of our other dimensions of our lives. Actually, it's about how we behave towards people, it's about how we treat them, it's about the values. And this really came home to me through COVID, where I had to do those daily stand-ups, you may remember.
I watched most of them.
Over 300 of them. And, I got quite a lot of feedback from the public, and I've talked about this before, that the one thing, and still, if not daily, weekly, I get people come up to me, and it could be in the Pack and Save, or it could be at the airport or whatever. And the thing they comment on, and especially the thing that they say their children remember, is that I was calm. Now, I didn't feel calm. Every time it was an ordeal. I was just hyper alert. It was absolutely high stress. But the thing people remember is that, and it's that lovely adage, people don't remember what you said or did, they remember how you made them feel. And there's the most fundamental ingredient to a good organisational culture is how leaders behave. And it's a full-time occupation. I say every person, every time. Every interaction is important, much more so than technical knowledge or management skills or charisma or ability to do great speeches or presentations. It's the way that you interact with people on an individual or collective basis that absolutely, as a leader, will help create the culture that helps organisations to thrive. And it's especially important in a complex organisation or a complex system.
Did you see any tangible outcomes as a result of, that shared understanding, that improvement in culture? Did you see any impacts in terms of staff morale, retention rates, or whatever? Like, was there tangible things that you could report to your boss?
Oh, absolutely. And interestingly, we've just had a paper accepted to the New Zealand Medical Journal that I've written with colleagues from my Hutt Valley DHB days, reflecting on our experience then. And actually, it's about the importance of training people in leadership and how profound even basic leadership training can be. And I just want to, the paper will be published soon, so I can't preempt it, but it's a really nice case study because we started with a real problem in our emergency department.
Yeah.
It wasn't performing, and we were about to lose our accreditation to train emergency medicine registrars, which is quite a big thing. And we did a review, and one of the things that came out was that there was a cultural issue there around behaviours of some clinicians, which we addressed. And then we put in leadership training, and then we put in some additional resource, but it was the shift in culture in the department that's still there now that actually led to, and actually that had an impact across the whole organisation. Just a little vignette here. One of our senior clinicians, who was at the time the clinical director of surgery, an orthopaedic surgeon, and some of my best friends are orthopaedic surgeons, but they're a particular, kind of personality. And after the first day of this leadership training, he was on the very first cohort. This is someone who was 2 years off retirement. He came to myself and the chief medical officer, and he said, I just wish I'd done this 20 years ago, because it was this, basic leadership training, but these profound insights into the role that you play and that your behaviours play and how you lead yourself and how important that can be for leading others, leading the organisation, leading culture, and so on. So if there's one investment that I think would make a huge difference across our system, it would be actually investing in people's leadership, training and skills and supporting them to be great leaders.
Amazing. Well, thank you, Ashley, for being a great leader and being a part of this podcast today.
Kia ora. Thanks very much.
Everything we cover in this session is for general information only. We are not tailoring our comments to your financial situation or providing financial advice or recommendations. This information and comments we provide are not intended to convey any guarantees as to the future performance of any investment products, asset classes, or capital markets. Past performance is no guarantee of future performance. Please refer to our full disclosure statement in the description.